Well, hello and welcome to this month's podcast, where we're going to bring you up to date with the latest information and data in the world of rheumatoid arthritis. It's a wonderful world, the old world of rheumatoid arthritis, and it's a particular joy for me to share in that particularly interesting world one of my IMED Forum Steering Committee colleagues, Professor Rieke Alten. Now, Rieke is the head of the Department of Internal Medicine Rheumatology at the University of Medicine Berlin, Germany. Rieke, fabulous to have you join me. How are you?
Thank you very much. Welcome also from my side. I'm fine, and we have two interesting papers today. One paper will be the paper by Maya Buch, and the other one by Bulos Haraoui. And in the paper by Maya, we are going to discuss the 165 data on Filgotinib. And the other paper is addressing Tofacitinib safety and effectiveness associated with cardiovascular risk factors, an always ongoing interesting question.
No, absolutely. Yeah, actually, this is a particularly interesting podcast. So I'm especially pleased to have you here to help me out as ever. And to those of you listening, whenever you need to get that detailed information, head along to imedforum.com. That's the website, imedforum, all one word.com. And that's where you'll find summary slides and a whole lot of other useful information. So I suggest, without further ado, that we get on with the business. So, Rieke, you're going to tell us about the first paper, the 156 interim result data. So over to you.
Actually, the first paper is written first author by Maya Buch for the whole study group for Filgotinib. As we all know, we have Filgotinib as a JAK1 inhibitor in two dosages, 100 and 200 milligram, once daily. And we can treat patients with moderate to severe rheumatoid arthritis who have responded inadequately or are intolerant to one or more CS-DMARDs. Filgotinib was evaluated in those with an inadequate response to methotrexate, FINCH 1, or bio-DMARDs, FINCH 2, and methotrexate-naive patients, FINCH 3, for which we have so far no approval, for instance, in Germany. But anyway, this study reports interim long-term results on efficacy, safety, and of course PROs up to week 156 in the so-called FINCH 4 study. And in this FINCH 4 study, there were nearly 3,000 patients included in the analysis. And interestingly, approximately half of these patients were methotrexate inadequate responders, 30% were bio-DMARD inadequate responders, and also one-third, 35%, were methotrexate naive at inclusion in the parent study. So among the methotrexate inadequate response patients, and this is how we use it normally in clinic, from FINCH 1 continuing to the further evaluation, more than 90% on the patients on 200 milligram and also 90% of the patients on 100 milligram achieved an ACR 20 from FINCH 1 to FINCH 4 baseline, reduced, of course, to 67%, 200 milligram, and very close, 59%, 100 milligram, maintaining this response to week 156 at the end of the study. So both dosages continued for the patients who were de novo treated with Filgotinib, and those who continued the treatment demonstrated sustained STARS remission rates at the end of the study, with a little bit higher rates observed in the 200 milligram dosage. So the same was true for CDAI. By the way, we just had an interesting discussion 2 days ago. The German rheumatologists still do not like CDAI. They are still very much sticking to DAS. I think the same is true also for UK. Anyway, continued FIL treatment was comparable with de novo, as I said already, treatment regardless of prior exposure. So to conclude, both dosages, 2 and 100 milligram, and this reflects also my daily clinical practice, demonstrated sustained efficacy up to week 165 in patients enrolled from FINCH 1, 2, 3, independent of initial background therapy. That is especially important after the PROC decision, where some colleagues tend to give it after TNFs. In Germany, we are still a little bit doing both after methotrexate because we can do it. So coming to safety, the safety data observed during the long-term extension were in line, which we have seen on Filgotinib so far. Actually, I looked up the herpes zoster dates because it's always an interesting in content of Filgotinib, and they were low. Actually, I dare not to say they are lower compared to all the other JAKs, but anyway, they are low also in this long-term observational study. So I think these findings may provide the clinicians with evidence that Filgotinib can continue to provide long-term clinical benefits to all our patients with rheumatoid arthritis, independently of the treatment line.
Absolutely. Well, look, thank you. That's a really clear summary. Yeah, Filgotinib, it's been an interesting player, hasn't it? I mean, it's probably the most JAK1 selective of the molecules that we're using in common practice. Having said that, whenever I look at long-term sustained efficacy, it's very difficult to make any kind of relative value judgment about the efficacy rates that are achieved, because there's the dropouts, there's the ways in which long-term follow-up data are reported. But I think it's a safe conclusion that if your patient tolerates Filgotinib, it's likely to be able to offer benefit in the longer term. And that, for me, is enormously reassuring, because we have to remember we treat a chronic disease. We can't yet cure rheumatoid. And so offering patients something and being able to say to them in the clinic, you know, people who tolerate this medicine are now on it for 3, 4, 5 years, and the safety profile doesn't seem to change particularly over time. So as we accrue that exposure over time, and clearly we're up to 156 weeks here, it does give us confidence. I liked your comment about not necessarily wanting to compare with other JAK inhibitors. And I think that I'd like to reinforce that. I think we have to be very careful not to make trial to trial and long-term follow-up to follow-up comparisons, both within class and also, to be honest, across MOAs. But I'm intrigued, Rieke, what are your top-line thoughts at the moment about, you touched on this idea maybe of what is the first choice now when we've moved away from conventional synthetic DMARDs? Should we be thinking biologic? Should we be thinking targeted synthetic DMARD? And let's, for ease of discussion, talk about a patient who doesn't fall into the black box warning, because I think that does change the dynamic quite considerably. But let's think of a 50-year-old person with rheumatoid arthritis who doesn't have a history of cancer or a cardiovascular risk that we're particularly. I mean, what's going on in your mind when you're thinking JAK inhibitor, biologic drug? Think out loud for me. I'm intrigued.
Actually, there are many patients who really like the oral way, and especially those, I see many patients here in Berlin who work in the government, and they have to travel a lot. And they don't like at customs if anybody sees that they have syringes with them. So that's a big advantage, that they can take it and nobody knows. And by now, rheumatoid arthritis is no more seen. That is very important. We don't have these damaged hands anymore. Patients look like normal human beings.
Yeah, that's very insightful. We have in the UK, and I don't know if this is the same in other parts of the world, but we have an advertising campaign which is actually really aimed at that, not just rheumatoid, but not all disabilities are visible. And I think I think that lack of visibility is, first of all, we must celebrate it because our patients are doing better. But it does mean that our patients, although they appear to be doing better, may well be hiding a magnitude of symptoms. I remember an amazing patient-led campaign a few years ago, which said, how are you? I'm fine. And of course, inside, our patients very often aren't fine. And if we can offer them that advantage, particularly the preference for an oral over a parenteral therapy, to us, it maybe feels like a small gain, but to the person with rheumatoid, that might be a huge part of their being in control, having ownership of their disease. Yeah, it's a great point. Look, why don't we crack on? Because I'm quite keen to hear about the Canadian data set. which was more focused in tofacitinib. So do you want to maybe talk about the Cantoral study?
Let me
And
just
then
say
we'll bring this
one
together.
little comment on what you said before,
Oh,
because
by all means, yeah,
despite the
absolutely.
fact that the patients say, I'm fine, they still are suffering from fatigue, you
Yeah.
know, and this is an unsolved riddle for us still, and it is not to be seen either. So that's very important point to address this in the future. But moving to Canada, to our colleague Bulos Haraouri, he published the Canadian data of patients who were enriched in this study, the Cantoral study, for cardiovascular risk factors. And this is, of course, very important after the PRAC decision, because Canadian, US, and also our European guidelines addressed the increased cardiovascular risk in patients with rheumatoid arthritis, especially in the all well-known study Oral Surveillance, which made a lot of turmoil, close to a tsunami in the rheumatology world. We have participated in all TOFA trials from the very beginning in the program. So actually, the data of the study, which is quoted here, has shown that TOFA 5 or 10 milligram twice daily failed to demonstrate non-inferiority to TNF. But that was the co-primary endpoint. The other points were really cardiovascular events, malignancies, excluding non-melanoma skin cancers, but all the rest made a lot of stress to all of us. So I think it's a good idea that here in this study, the real-world Canadian observational study addressed tofacitinib safety in patients meeting or not meeting cardiovascular risk factors. And in this observational study, with all the limits these data have, they compared cardiovascular risk factors cohorts. The patients with risk factors were older, had a longer disease duration, and this might be one solution to one of our questions. Of course, a higher proportion of smokers, and were more likely to be male. I'm sorry for that. The disease characteristics were very similar between the two groups. The cardiovascular positive cohort experienced higher incidence of treatment adverse events and serious adverse events, but interestingly, a numerically lower incidence of discontinuations due to AEs compared with the negative cohort. So the mean time to all-cause discontinuation and discontinuation due to AEs was similar between the cohorts. The time to discontinuation due to lack or loss of efficacy was longer in the positive cohort. By month 6, similar proportions of patients with these cardiovascular factors or not factors achieved remission in CDAI or low disease activity. So, as I said before, patients with higher cardiovascular risk profile were generally more likely to experience a safety event, especially those aged over 65, as already regulated in our black box warnings. So clinicians should assess the benefit risk of treatment, including cardiovascular risk assessments and management, to inform and to make an individualized decision for each patient. But the problem is rheumatologists are very busy. And my question is, do we now always also to have a risk checker for our patients for the cardiovascular risk? What is your opinion on this?
Well, I'm going to cause trouble for my dear friends listening to the podcast by saying, yes, I think we do. And I'll explain my rationale. So before you throw your coffee cup at the computer screen, remember two things. First of all, you paid for the coffee, and secondly, you paid for the computer. So I'm only going to say what I think. If you go to a diabetic clinic, the patients will expect to have their urine checked. They will expect to be asked about their vision check. They will expect to be asked about symptoms of peripheral neuropathy, and that is because of their intrinsic parts of the diabetic condition, and we could go on. And I think the rheumatologist who is providing comprehensive care for rheumatoid arthritis, and by the way, I would include in this conversation the seronegative and psoriatic arthritis populations also, because I think there is pretty good evidence of accelerated cardiovascular risk there as well. I think we must at least take responsibility for helping the patient to own the problem. Now, it may be that we delegate that out into primary care if there is a strong primary care network in countries in which we practice, but we must at least take responsibility for that being part of the care package. So patients in Glasgow will have their blood pressure measured, their weight measured. We will talk about cholesterol. We will talk about psychological well-being. And in fact, I often smile at back in the old days, if patients come in and they hadn't been weighed, quite often they would start the consultation by saying, I know you didn't get my weight today, and that's because I know I put weight on and I know I should be doing something about it. In other words, it's about having the conversation, Rieke, isn't it? So you're right, consults are complex, but by giving patients ownership of the different morbidities that afflict people with rheumatoid, I think a key part is once the patient understands that they are at cardiovascular risk, that they do need to keep their weight well controlled. I mean, one of the paradoxes of better disease control in rheumatoid arthritis is that obesity is creeping into our population. And that's a bad thing, because obesity and rheumatoid makes one, by definition, multi-morbid, and multimorbidity carries all of its own risks. So I think your question is a really good one. I take the view that as rheumatologists, we, together with our patients, always in partnership, need to say that these are important issues. And whether it's me that prescribes a statin or a blood pressure lowering medication, it doesn't need to be the rheumatologist that writes the script, but we do need to own the decisions to say to the patient, are you and your doctor dealing with your blood pressure? Have we thought about your cholesterol? Because, you know, oral surveillance, one of the most striking findings in oral surveillance is how many of the patients in that trial did not have their primary cardiovascular risk managed. And that's in itself a wake-up call. We could save far more lives by just simply managing that prophylactic care than we would ever save by worrying about some extra MACE events in subgroups of rheumatoid patients receiving JAK inhibitors. So I think that call to action to be aware is really, really important. So sorry, I went off on one there, Rieke, but you picked up one of my favorite topics, actually. And I am very sympathetic to how busy clinics are, but if you give the patient ownership, then actually they will come to you and say, excuse me, but I'm worried about my blood pressure, I'm worried about this, and that prompts you to instigate action. But those are my thoughts. I mean, what about you, Rieke? Do you agree? Do you disagree? You're allowed to disagree, of course you are.
I changed my behavior since 1 year around, since the first data came out with surveillance. And I do blood checks for cholesterol, and I do talk together with my patients. And I really recommend also treatments.
Yeah.
And I try, of course, to involve the GPs, but my experience is not so good. So I have to take the responsibility. And we do also weight check, and we talk about obesitas, etc. And actually, we can find the time.
You know, one of the things my patients often used to tell me, when they're having their blood pressure and weight measured by the nurses before they come in to see us in clinic, that's precious time for them. And you know how often one of the amazing nurses in our clinic, they would just pop their head into the clinic door before the patient comes in and says, you know, I just had a great chat with Frau Schmidt or whatever. You know, she's not feeling so great at the moment. And, you know, she was telling me her kid's been sick, or she was telling me, and this is about the humanity of medicine. It's about treating the totality of our patient, isn't it? It's about treating people, not patients, actually. And I think just that time can complete the circle of care that I think rheumatologists are really wonderful at delivering. So yeah, Rieke, I completely agree. I'm very excited to hear the change in practice that you've enacted. A couple of things maybe about this paper, though. You know, we were chatting away about it. It's curious, isn't it, that those patients who were potentially at higher risk maybe discontinued medicines a bit less. You were commenting on that. Any thoughts as to why that might be?
Actually, maybe they had all other treatments had before, so they stick to it in an irrational way, but because they have no other options.
Yeah, yeah. And that's, I mean, what you're touching on is the art of medicine, isn't it? And that's where, I mean, our EULAR recommendations are fabulous, and there's no doubt that EULAR, ACR, other recommendations and guidelines have transformed care because they've normalized and regularized care across the world. But they should never take us away from the need for us to consider the individual needs of people in front of us. And Canadian rheumatologists are amongst the best in the world, and they clearly are continue to exercise that individualized quality of care, aren't they? Which is great. Well, look, Rieke, what I think taken together, we're once again seeing a reassuring picture in the real world, which doesn't mean we ignore oral surveillance. Quite the contrary. I think oral surveillance, and especially black box regulatory warnings, need to be taken with the utmost seriousness. But I think the real world data, the more and more of them that we look at, suggests that as a discipline, we're managing those risks and individualizing them with our patients. And I think that for me is the key take home. But what struck you most about the papers we've reviewed this time round?
Actually, I'm happy that we can really contribute to this knowledge by our rabbit registry, for instance, because we have seen the changes very early. And I think the German rheumatologists, not to be proud of my colleagues, but they have taken very early on consideration which patients to put on which drug. And as I talked in the last days, there has been also a very positive change again versus small molecules because everybody is reflecting more.
Yes. And well, and it's not just because you're here, but Rabbit has been one of the fabulous registries that has really transformed our practice. And along with the other registries across Europe and some of the registration registries that we have in North America and elsewhere, we have learned so much. And I think increasingly, I mean, if some of our listeners are interested, there's a fascinating debate taking place in the literature about the use of controlled trial as opposed to real world evidence to define efficacy and even potentially in the future registration of medicines. So watch this space. It's going to get really, really interesting. Well, look, Rieke, time is against us, and I'm going to have to say many, many thanks to you. I always love listening to you. I always learn from you. So thank you. And to you, our dear listeners and watchers, if you want to see the full publications uploaded this month, and as ever, to look at other podcasts and resources, head across to imedforum.com. And don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel. Make sure that you don't miss any podcasts in the future. You don't want to miss podcasts because, you know, they're always worth a listen. Even if you don't agree with them, they're always worth a listen because really they're designed to make us think. And as always, do let us know what you think by leaving a review. Thank you for your attention. So Rieke, thanks ever so much to you for joining me today. It's been great to have you with me. And to all of you, wherever you are and whatever you're celebrating in this holiday season, I wish you good times with family and with friends, and especially at the moment, a peaceful 2025. We could wish for nothing more and nothing better. So thank you to you all. I wish you the very best. Bye-bye for now.
Thank you.